Hello friends, in this video I would be talking about the various questions that have been asked in the INI-CET November 2024 regarding the subject of ophthalmology. Now you would ask me, sir, why these questions are important? These questions are important because the topics that have been asked can be repeated in the forthcoming exams. So the topics which have been asked in the INI-CET November 2024 can be asked in your NEET PG 2025, or the questions which have been asked here can be asked in the further INI-CET exams, let's say May 2025 or November 2025 exams. So that's why I give a very much emphasis to the revision of the previous year questions of at least 5 years. So what were the various features of this exam in the INI-CET November 2024? So in the ophthalmology part, I would say that usually we get around 5 to 6 questions, but this time we have got around 12 to 13 questions. So there is a double the weightage. Second thing is, usually these questions are around moderate to difficult level. This time also it was moderate to difficult level, or I would say more difficult than the previous year papers. And there were a lot of questions from the chapter of retina. Earlier, the emphasis was more on the systemic ophthalmology, but this time emphasis was more on the chapter of retina. One question was a totally new question. The topic was never being asked earlier, and the two questions were controversial questions. Let us find out what were the various topics that have been asked. So the first question was, a couple brought a newborn preterm baby that was delivered at 32 weeks and was weighing 1400 gram with white pupillary reflex. On ultrasound or oblique CT, there is a calcification seen. What is the probable diagnosis? So let us see what are the various hints that were given in this question. So the first hint was there was a newborn preterm baby. The second hint was the child was 32 weeks oblique 1400 gram, and a very important hint was white pupillary reflex, that is, I would say, leukocoria. Now they have given the most important hint here, that is, there was a presence of calcification. What is the probable diagnosis? So if I see the first line, it becomes clear that there is a preterm baby. So you would be thinking more about the retinopathy of prematurity here. But that is not the answer. The answer here is retinoblastoma. Now you would say, why, sir? Because a very important hint that is given here, that is the calcification. Calcification occurs only in the retinoblastoma. Okay, it does not occur in a complicated cataract, Coats disease, or ROP. But you would ask me, sir, why it has happened in a preterm child? So usually retinoblastoma is more common in 2 to 5 years of age group, but a bilateral retinoblastoma, or in Indian scenarios, whenever you are getting a leukocoria with calcification, your answer would be retinoblastoma. So, though all of these options, whether it is a cataract, Coats disease, or retinopathy of prematurity, all of them can cause a leukocoria, but the calcification occurs only in the retinoblastoma. Now you can see this, that I have told about the retinoblastoma. Most importantly, I have highlighted the calcification in our lectures and have told you about its presentation. So please do revise our lectures again from the app and the notes. You would always do these questions correctly. The second question was, a 60-year-old female presented with bilateral, sudden, painless diminution of vision. Which of the following can be the probable cause? Now, what were the hints that were given? So the first hint that was given here is there is a bilateral. Second hint was sudden, painless diminution of vision. Now let us see various options. So my first option was acute angle closure glaucoma. Now acute angle closure glaucoma, the patient would come with painful decrease of vision, and same with the option D, where there is a uveitis. Here also there would be a painful decrease in the vision. Keratoconus, though it would be painless, but in a patient of keratoconus, there is a not sudden but gradual decrease in vision. So what becomes our answer here? The answer becomes diabetic retinopathy. So sometimes you may ask me that, sir, why a diabetic retinopathy patient would come with sudden loss of vision? Remember, I told you, in the patients who are having a proliferative diabetic retinopathy, they can have retinal hemorrhages like vitreous hemorrhage, and whenever you see vitreous hemorrhage, it can cause a sudden painless diminution of vision, and we all know that the diabetic retinopathy occurs bilaterally. Okay, so that is how B becomes the answer here. Now, I have told you about the diabetic retinopathy and specifically have shown the diagram. So remember, a vitreous hemorrhage can be there as a presentation in a patient with proliferative diabetic retinopathy. You can see it in our diabetic retinopathy notes. A screenshot of that note, I have shared it here. The next question was, which of the following would be seen in macular corneal opacity? And some students were asking that the question was there, macular corneal dystrophy. The answer remains the same. So whenever we are talking about the macular corneal opacity, we all know there are three types of corneal opacity: nebular, macular, and leukomatous. In macular corneal opacity, there is involvement of around 1/3 of stroma. So when 1/3 of stroma is involved, what happens is, though you can see the iris, but you are not able to see the iris details. So in nebular opacity, you can see the iris details, but in the macular opacity, you are not able to see the details of the structures that are inside the cornea. So my answer of choice here would be only iris visible or only pupil margins visible, okay, not anything else. Let us see what are the other options that were given. Pupillary margins and iris details are visible. I told you that the details are not visible. Only pupillary margins are visible. That is also wrong. Yes, we can see the iris, but not the iris details. And here it is written iris is visible and pupil not visible. This is also wrong. You can see the pupil also. Now this was a word-to-word question that has been taught in our cornea chapter. You can see our cornea notes, and here I have specifically written here that if you can appreciate that whenever there is a macular corneal opacity, the iris details are partially visible. Okay. The next question was the easiest of the lot, and it was, which of the following is the investigation of choice for best vitelliform dystrophy? Now this question was a repeated question, though it was not in the last 5 years, but between 5 to 10 years. So sometimes the questions can be asked in at least the minor subjects like ophthalmology, which are between 5 to 10 years. So I would basically recommend you that the important topics of the chapters and the questions which have been asked from 2013 to 2018 should also be done. Now the question was regarding the investigation of choice for best vitelliform dystrophy, and we all know that what happens in a best vitelliform dystrophy, that around the macula you see yolk-like appearance, and in these cases the best investigation is electrooculogram. We see the Ardens ratio, and this Ardens ratio is decreased. Okay. You can see the investigations in our chapter of investigations in ophthalmology, and as I have highlighted it here, the second line in the electrooculogram notes, I have written that it is the best investigation for best vitelliform dystrophy. The next question was, how are the microaneurysms seen in fundus fluorescein angiography? Another question from the chapter of investigations in ophthalmology. So the options were hypofluorescent dots are given, hyperfluorescent dots are seen, hyperfluorescent area in branching pattern is seen, and the last was hypofluorescent lines. So answer becomes clear here. It is hyperfluorescent dots that are seen. Now you can see it in our notes as well. I have given this specific picture. This picture, as you all know, is of non-proliferative diabetic retinopathy in fluorescein angiography. And what you can see is that these white hyperfluorescent spots all over the retina, these white hyperfluorescent spots all over the retina, these are the microaneurysms, which you all should know that is the first manifestation in non-proliferative diabetic retinopathy. Please see that this question was also word by word repeated from our notes. See, I have written they are multiple punctate white hyperfluorescent spots. So there is no doubt in the answer of this question as well. The next question was, which of the following is true regarding the viscoelastic substance used in the cataract surgery? I would also consider this question as a new question. Now, whenever we do a cataract surgery, what we do is, after making an incision in the cornea, we basically put a viscoelastic inside. Now this viscoelastic, what it does is, it basically maintains the anterior chamber integrity so that you can basically go inside with the other instruments and do your steps of capsulorhexis as well as phacoemulsification. Now let us see what are the other options. So the answer is clear, that is A, that it helps to maintain the anterior chamber while doing the other steps like capsulorhexis and intraocular lens insertion. Now the other options is, it can cause mechanical injury to the corneal endothelium. Now this is typically false. Why would we do something which can basically cause damage to the endothelium? We won't do that, okay? So sometimes it is not just the basic knowledge, it is the basic thinking that would basically make your question correct. Now the next option was, SF6 and silicone oil are the commonly used viscoelastic substance. No, they are not the viscoelastic substance. We use in the pars plana vitrectomy whenever we do it for rhegmatogenous retinal detachment. We basically give internal tamponade with these gases. The viscoelastic substance are left inside the eye after the cataract surgery. This was the fourth option, and this was also wrong. Remember, when I was talking about the various steps of phacoemulsification, I told very clearly that after the intraocular lens insertion, we do irrigation and aspiration. And why we do irrigation and aspiration? To remove the viscoelastic. So this is also wrong statement, and you can see that this was also being taught in our video, where I have specifically written that we are inserting a viscoelastic, and I have named it also like a HPMC, and that basically helps to maintain the integrity of anterior chamber. Another question straight from the notes. The next question was, diabetic retinopathy leads to which of the following? Your options were posterior staphyloma, retinal detachment, myopia, retinoschisis. Another very simple question, which the answer is, you all know, retinal detachment. And which type of retinal detachment occurs? This is the tractional retinal detachment. Okay, remember the posterior staphyloma, this happens in the patients of high myopia, and retinoschisis is also seen where there is a splitting of inner layers of retina. That also happens in the patients of myopia. Okay, now this question you can also see is a direct question from our notes. When I was talking about tractional retinal detachment, the first cause that I have written it here is proliferative diabetic retinopathy. You can just see our videos and see this question. The next question was, which of the following is not found in the inner segment of photoreceptor cells? So this, I would say, is the only question which has been not from our notes or videos, and I have seen that this question might be a bit of controversial question, because mitochondria, Golgi bodies, and endoplasmic reticulum all are seen in the inner segment of photoreceptor cells. These are the rods and cones. But the last option which they told, disc membrane, actually does not make the sense, so is my answer of choice here. Now a few words regarding the rods and cones. These are our photoreceptors, as you can see in our diagram. These are rods, and this, as you can see the shape, this is the cones. Now what you can appreciate in this diagram is that this area, this has the pigments. Okay, so the rod lamella, you can see this have the pigments, and this is our segment which has been asked here. So this segment is having the cell body with the nucleus, Golgi apparatus, and mitochondria. Okay, so these all cell organelles are seen. What has been not seen is something like a disc membrane. I don't know what they want to ask. The similar thing happens in the cones as well, where you can see the Golgi apparatus, you can see the inner segment is having the cell body with the nucleus, and the outer segment is just having the pigment. So all the organelles they have mentioned in the question are seen in the rods and cones, but the disc membrane, I don't know what they are asking about, is my answer of choice here till further clarification. The next question was, pterygium can cause decrease in vision due to. Now, another question straight have been asked in many exams in last 3 to 4 years. Now, we all know that what happens in the pterygium is that it causes decrease in vision due to astigmatism. Let us see the other options. Corneal edema does not make sense. It is not a conjunctivitis, so discharge also does not make sense, and the macular edema does not make sense. So this is the easiest question of the lot. The answer here is astigmatism. Now you can see this question also directly from our notes. If you can see here, I have marked it. Astigmatism is the most common cause of decrease in vision in the patients of pterygium. The next question was a bit of controversial question, and I would say more clinical question. A patient presented with the chemical injury, some students were saying that it is after 2 to 3 hours. What is the first line of management? Now, what is the management? Whenever we talk about the management, we have to make sure that we talk about the history, we talk about the clinical examination, and then we go towards the treatment. Management has all of these. A similar question which was asked few years back, they have asked about the Chuna injury. Now, Chuna injury, you already know that is a alkali injury. Here they have not mentioned what is the chemical that has been put. Now, what is the first choice of treatment and first choice of management? Now, my answer of choice here would be take history. Now, why this is my answer of choice here? It would take hardly 10 to 15 seconds. You have to just ask the patient that how you got the injury. If there is a acid attack, there is a medical legal case, you have to document it. Okay. If there is a tuna particle injury, you have to do a double eversion also to see if there is any particle inside in the fornices. So taking history and documenting it is very important. It hardly takes 10 seconds till you do the next step. What is the next step? It is also the immediate. If the take history was not there in the option, I would have basically jumped to the second best option, that is the copious irrigation. So take the history, very quick history within 10 to 15 seconds, and shift the patient to the bed and start copious irrigation for 30 minutes. So my answer of choice here is taking the history followed by the copious irrigation, though both of them should be done simultaneously. First take the history and then do the irrigation. It hardly takes 10 to 15 seconds. You can also see this question regarding the chemical injury. This is also being taught in our ocular trauma chapter, where I have told that whenever you start the chapter of chemical injuries, I told you about the acid and alkali injury, and the alkali injuries are more dangerous than the acid injuries. So start with the history taking and then go to the management, but it has to be a brisk management. The next question was another question regarding the retinal anatomy. So we have got two questions. There they have given the various layers of retina, and then they have asked about what is the order. Now, first thing you can see, if this was the diagram and this is a pigmented layer, whatever is pigmented layer, it would be towards the choroid, and this layer would be retinal pigment epithelium. Then you can see definitely it is very clear that these are the rods and cones, and you have their nuclei here. So number 3, this is the outer nuclear layer. I want to have your attention towards the fourth thing that they have asked. What is this? These are the ganglion cells. These are our ganglion cells. So our order becomes RPE followed by rods and cones, outer nuclear layer, and ganglion cells layer. This also, all the layers of retina are being told to you in our chapter of basic retinal anatomy. See the timestamp 14 minutes 34 seconds and you would see the diagram with the order. So very easy here is that they have asked the order. So you all know that the rods and cones are followed by the outer nuclear layer, and the retinal pigment epithelium is above the rods and cones. So you have to just identify the retinal pigment epithelium. You know that this is a single layer structure which is in approximation with your choroid, and as soon as you know that which layer is the outer layer and which layer is the inner layer, you would get the answer. So please see this chapter of basic retinal anatomy again from our app and our notes. So the next question was, what is the ratio of caliber of artery and vein as it passes through the optic nerve head? They are asking about the AV ratio, the arteriovenous ratio. I told you when I was talking about the chapter of hypertensive retinopathy. So I told you that the arteries and veins, they pass through the optic nerve head, and this arteriovenous ratio normally is 2:3. Whenever the patient is having a hypertensive retinopathy, or I would say chronic hypertensive retinopathy, it decreases to 1.5:3 to 1:3. Okay, so the answer here is C, that is 2:3. You can see this from our notes, as I have seen it written it very clearly. You can see that we have the arterial vein caliber which is 2:3, that is the normal one, and as the hypertensive retinopathy sets in, it becomes 1.5:3 to 1:3, straight from our notes of hypertensive retinopathy. Now we come to the last question. The question was, not a derivative of neural crest cells. The options were ciliary ganglion, ciliary muscle, choroidal melanocytes, and retinal pigment epithelium. So this question is basically an anatomy and embryology question, but it has the options which are related to ophthalmology. That is why I have put this question here. Would be discussed by the anatomy faculty in the detail. But remember, whenever they are talking about the neural crest cells, retinal pigment epithelium, this is not from the neural crest cells. This is from neuroectoderm. The rest of the following, ciliary ganglion, ciliary muscles, choroidal melanocytes, these are from the neural crest cells. The details would be taught to you in the embryology section by the anatomy faculty. So with this, we come to the end of this discussion. Hope you would have liked the discussion, and if you have any doubts, you can put it in the comment section. Please revise these questions again. Please revise these topics again. That is how you go forward for your NEET PG 2025 preparation. Till then, all the best from my side. God bless.